Great. So it is my pleasure to welcome back Rob, and this time with his very able associate Oliver. So Rob, he's currently the director of health economics at Dark Peak Analytics. Prior to that, he was at University of Sheffield. He was also he was one of those modelers that informed a lot of COVID-related decision making in the UK when he was at the UK Health Security Agency. Um, he has a host of experience building models for a variety of disease areas, and we're excited to hear some of the work that he's been doing recently, following up on prior work that he presented here on really trying to merge health economics with access to places that you can exercise using a lot of sophisticated geospatial analyses. He's joined today also with Oliver Dolin, who got his undergraduate degree at Oxford and then got his master's at the London School of Hygiene and Tropical Medicine. He now is a health economist at Dark Peak Analytics. And with that, I'd like to welcome them here, and I look forward to hearing their new research.
Thank you so much, Aaron. It's lovely to be back, and I hope we can tie it in nicely with the previous presentation we gave roughly or just over a year ago in Barcelona, which is a much more glorious location than from Sheffield. But yeah, so we'll hopefully tie it in nicely. So last year we gave a talk where we were looking at access to parkrun events for physical activity. And this was based on a bit of work that I did with Paul Schneider when both of us were at the University of Sheffield. And we were looking at how do we improve access to community physical activity events and parkrun running events that take place every Saturday morning. And we built this geospatial model that searched through all of the green spaces in England and identified the optimal new site locations for those events. And we published a whole series of papers on this and gave a talk with you guys, which you kindly shared the recording, and we've put that online, and I believe that you've shared them on YouTube as well. So what we've done since is adapt that methodology and apply that to access to healthcare. So, and the defining argument here really is that access shapes outcomes. So which treatments patients pick or the treatments that they're able to take and how well they adhere or stick to that treatment. And this is the case across many different conditions. So that ranges from cancer, HIV, depression, schizophrenia, anything where the treatment and distance to treatment will affect outcomes. So why does this matter? Unequal access contributes to health inequalities through poorer health outcomes. It also means unnecessarily high costs, and improving access therefore benefits patients, benefits providers, and it benefits payers in the healthcare system. And the idea is that by improving access to healthcare, we have increased uptake, so increased initiation of certain types of medicines, and also increased adherence, and therefore improved outcomes. And those outcomes may range from health outcomes for the individual patients, reductions in healthcare costs for the healthcare providers, and potentially reductions in things like CO2 and increases in productivity due to reductions in time lost traveling. And so the challenge for us in this project is how can we quantify where gaps in access exist and how can we prioritize new sites to maximize the benefit from the provision of new treatment modes or creation of new sites in a geographic region. So what we want is a scientifically robust framework that we can build off of that's applicable to multiple different treatments in a given geographical region or country. So what we've done is gather diffuse data sources. So in England, we have data on the location of trusts and GP practices, so family practitioners. We have very good data on at the lower super output area level, so the small geographic area on deprivation, population size, age, and sex characteristics. And we also have open source routing mechanisms and map provision. And so combining all of that information with a model that we've built in R and C++, we're able to help in some small way, I hope, guide decision making by industry and by the NHS. So what we're going to describe, and I'm going to let Oliver go through the bulk of this, is how we measure geographical access to care across England, estimate how improving access would influence key outcomes of interest for us, and identify those optimal locations for additional service sites. And we're going to do that for a case study with some dummy data in this case, and showcase a web-based platform that allows you to do this live. What we want to do, though, is to understand the different stakeholder perspectives and what might interest these different groups. So the NHS obviously has severe capacity constraints and therefore is very interested in resource use. Patients might be interested in things like the convenience, how quickly they can access a site, and their out-of-pocket costs associated with traveling to sites. Industry might be interested in the revenue from products, but patients and the NHS are also interested in the equitable coverage across society, treatment availability, and ultimately patient outcomes. But there's the wider societal effect, including things like the environmental impact. Having people travel large distances across the country to receive care obviously has an environmental effect, and also economic productivity. So can we treat people closer to home in a way that's more convenient for them and allows them to be more economically productive? So I'm going to hand over to Oliver to carry on for data analysis.
Great, thank you. So I'll start just by briefly talking about some of the data that we used, and then I'll go into the actual analysis framework. So I won't go into a lot of detail here because Rob's covered this already a little bit, but we have data from a variety of sources. So our dog's coming through. So we have data from a variety of sources, including the Office of National Statistics and then various resources from the NHS itself. But the key thing to note here is that the kind of unit of analysis is what's called a lower super output area. And that's a very small region within England that has a population of around 1,000 to 3,000 people. And we use this sort of level of granularity because it's the most, is kind of the lowest level of granularity we can get that also still provides meaningful demographic information. We use that to kind of measure access for groups of patients. So our overarching goal is given a set of kind of existing sites and a set of potential treatment sites, is to identify which of those potential treatment sites are the best treatment sites to build or develop. We start out by identifying where patients and current sites are located. We estimate the outcomes, the current outcomes, given the existing access to sites. And then we systematically evaluate the set of candidate sites to understand how outcomes would change if candidate sites were included, and then rank them based on a particular objective function. For example, the amount of distance that patients travel, their out-of-pocket costs, things like that. So in a bit more detail, so if you imagine our goal is to minimize the distance that patients travel to care in England, and we want to know the 20 best sites to do this. We start by calculating the distance that patients travel for existing sites, travel to get to existing sites. Then we, for every candidate site, identify which LSOAs would switch, so which patients would switch from traveling to an existing site to that candidate site, and we calculate the total reduction in distance that patients across England have to travel. We do this for each candidate site and identify the candidate site that reduces the distance the most that patients travel. We add that site to the ranked list, and then we take that site, add it to the set of existing sites, and repeat the process until we have filled up the ranked list. So in practice, I'll show you what this looks like with a simplified example. So if each one of these, imagine this is kind of a map, and each one of these little polygons is an LSOA, and each of these little black dots is what's called a population weighted centroid of that LSOA. So that's where, on average, people who live in that LSOA are located. And you can imagine getting this point is essentially taking the coordinates of every person who lives within that region and averaging the kind of X and Y coordinates to get the average or center of mass of where people live within that LSOA. And when you use that centroid to estimate the distance that people have to travel within that LSOA to get to an existing site. So from here down to this site down here. So the greedy search process that I just described goes as follows. So first, we calculate the distance patients are traveling to the existing site. So that's A here. Then we consider how far patients would travel if they were traveling to the candidate site, so if the candidate site was included. And we always assume that patients will switch to travel to whatever site is closest to them. So we do this for all of the candidate sites or potential sites under consideration. So that's B and C here. Then we sum together the distance traveled, which is the outcome we're interested in here. We're trying to minimize distance. And because site B minimizes the total distance traveled the most, it gets added to the ranked list, and then it gets included among the set of current sites before we repeat the process. So the reason why we add the candidate site that won kind of that round to the set of existing sites is to prevent a bunch of clustering of sites within a particular area. So if this kind of area on the map where you see D and B would be a very good location for a new site to be placed, once B is placed there, we're interested in the marginal effect of adding an additional site once B is there to prevent getting a bunch of results within a small area like this. Because now that B is there, D is no longer the next best site. C is much more promising. So moving on to the next round of the search, B has now been included. We now consider what outcomes would be with C. Because we're looking at minimizing distance, adding new sites can only reduce the distance that patients travel, but this isn't necessarily the case with other outcomes where patients switching to a closer site might actually have a negative impact on an outcome. But in this case, it's much more straightforward. Adding a new site will reduce the distance that patients travel, and so site C is then added to the rankings and is the next result. So overall, in this case, we used a simple objective function to identify the candidate sites that minimized the sum of distance traveled. In practice, this process is occurring across England for tens of thousands of these little LSOAs, hundreds to thousands of existing and potential sites. All right, I'll hand over to Rob now to go through some more of the methods.
Thanks, Oliver. So in order to do this, we first need to know where the prevalence, so where the prevalent population are located, how they're distributed across the country. Because when we're talking about our population in each of those small geographic areas, each LSOA, we're not talking about the total population, we're talking about the prevalent population with a given disease. So if we're talking about, say, HIV, we want to know in each of these LSOAs how many individuals require treatment. And so what we do is we combine demographic and prevalence data and estimate the distribution or the expected number of eligible patients in each of those LSOAs. And there's different methods to do this, ranging from relatively simple methods, just incorporating demographic data, to more developed methods or using external data sources from models that have already done this. The other thing that we need to do is to understand the travel times, so the distances between each of the LSOA centroids and the existing and candidate sites. Previously, when we described the parkrun work we did in the last presentation, that was all done using essentially geodesic distance, so the distance across the surface of the Earth, which is very close to the Euclidean distance, so just a distance as a straight line between 2 points on a plane. We've now extended that method and improved upon it to actually use driving distance. So as you would use on, say, Google Maps when you're driving your car from home to work. So, and we've done this using open source routing machine software and OpenStreetMap in for the English road network. And so we calculated the pairwise travel times between each LSOA, so each of the 33,000 LSOAs, and each of the sites to give a total of 6.5 million routes. We then validated this by cross-checking, does the distance and duration make sense? And what does that say, or what is that predicting about the speed? So obviously, if we're getting results that meant that people were assumed to be traveling at 100 miles per hour, then something's wrong. And if we're assuming that everyone's walking, then something's wrong. But you can see our kind of range from 5 miles per hour to 70 miles per hour. All of our data points fit in there. So we're looking broadly correct, with lots of people traveling on, like in the UK, an A road is a 50, 60 mile an hour speed limit. So pretty normal speed to be driving at. This bit is apparently the most tricky part of the project and the platform, which is understanding the relationship between distance and initiation and adherence of any given set of medicines or treatments. And this is the bit that we'd really like to get feedback on, is how best to model these relationships. What we're trying to do here, and what we've done in a simple example, is to look at, for any given set, say of 3 treatments, treatment A, B, and C, what is the kind of treatment share of each of those over each distance. So, for example, at 5 kilometers, you might expect that patients would be recommended to potentially come into site. So if they live near their GP practice and they can attend for a subcutaneous injection, that's very convenient because that's a very short drive. They can fit that in around their daily schedule. However, if somebody lived a 2-hour, 3-hour drive from their nearest site to do some, for example, an IV or something else, if they live in a geographically remote region, they might instead choose a daily oral treatment. So understanding these relationships, I think, is really important, but really tricky. So we're kind of searching for data on this for different conditions. So then once we have those kind of 2 key drivers, so where people are and the relationship between distance and treatment share, we can then look at different outcomes of interest. So we're particularly interested in NHS costs, patient productivity loss and out-of-pocket costs and convenience, and total number of treatment administrations. So does this improve both adherence and initiation of treatment? And then other things are fairly straightforward to calculate, like CO2 emissions from reduction in driving and travel. So I'm going to hand over to Oliver to do the cool bit.
I'll also add, if anyone's interested in kind of some more details of how we've calculated those outcomes, we have that in an appendix, which we can go through after we finish the main presentation. Let's see. Is that sharing all right? Assume yes. I think it's sharing the whole screen, right?
I think so. Check. If anyone's able to shout to say that they can see the screen.
Yep,
I think
looks good.
Yeah.
Okay,
Awesome.
great.
Cool.
Thank you. Okay, so when you open the app, so just before I go into any of the details, just want to emphasize that the data in here is dummy data. So we are kind of set what we think are somewhat reasonable parameters for some of these outcomes, but the treatments are arbitrary treatment A and treatment B, and the existing and potential sites are a random set of existing trusts in the NHS. So the idea is when someone's opened the app first, they're presented with what the outcomes are for patients within that region. So in this case, England, for the existing sites. So that's everything here. Where the idea would be that they could select whatever disease that they're interested in, and then start narrowing in on a particular region where they're interested in understanding which of the potential sites, so those are the sites in blue, are the best sites to build or develop. So for example, right now all of England is selected, but I could focus on the south of England here. And we can see that kind of highlighting that that's the area under consideration, but I'll leave this as all of England. That there. We also have descriptive statistics for each of the LSOAs here. So that's the little tiny region, and I can zoom in here in a second once that's loaded so that you can see just how small some of these regions are. Give that a second to render. There you go. So they're quite small regions, and you can see in towns they get even smaller because the population density increases a lot. But we have the population of these areas and other demographic statistics like the expected disease prevalence, number of cases, IMD score, which is a score that represents the relative deprivation of the area. And then also the nearest hospital or trust and the directions. So this opens like a Google Maps link. So once someone has selected a region of interest where they want to know what the best candidate sites are, they need to decide how they would measure what a good candidate site is. So they could try and minimize the distance that patients travel within the region of interest, minimize the travel time itself, or maximize the number of treatment administrations of a particular treatment. For example, if we know there's a new treatment available that patients are more likely to take when they are very close to sites, but less likely to take when they're quite far away, we might want to maximize the administration of this treatment. So I'll show you what this looks like for travel distance. And I'm going to do this just for a small number of sites so you can see very clearly where the sites pop up. And I'll remove the candidate sites so you can see where there's kind of gaps in the map. So here it's quite clear there's not a lot of existing sites. Sometimes you get sites that look closer to other dots on the map, but that's because there's like a high population density near those dots. So there's a lot of people that don't have kind of care nearby. We can see the impact of building all of these sites here in the headline tab. So this is updated with, we have the original outcome value here, the improvement, and the current value, assuming you were to build all of the candidate sites. We can break down the impact of this by IMD quintile. So IMD stands for the index of multiple deprivation. That's a measure that's commonly used in England to measure the relative deprivation of an area, and each one of these LSOAs is assigned an IMD score. We've broken each of these LSOAs into quintiles based on their IMD score, and then looked at how many patients are in particular quintiles. And we can also look for particular outcomes, for example, the average distance traveled, what the relative impact is in each of these different IMD quintiles. So we can see that patients who are in a most deprived region, the most deprived regions tend to travel less distance, which is kind of consistent with very deprived regions being in cities where distance to care is normally less. We can also see the change in the outcome across the set of existing sites, and then also if you were to build the ranked candidate sites. A couple more features to demonstrate are that you can look at the impact of building individual sites. on outcomes. And that's because we think users might potentially only have limited resources or be interested in understanding how only a subset of the ranked sites, what the impact of building only a subset of the ranked sites would be, maybe because of other considerations that aren't taken easy to take into account in the optimization algorithm here, like the cost of opening up a new center or other qualitative considerations. And the final thing to note is that all of these outcomes have parameters here that are editable, so that you can update the way that the outcomes are calculated. So for example, if we can look at the kind of here, the headline figure for out-of-pocket costs is around £18. If we have underestimated the cost of traveling, we can update the underlying parameters for that calculation and go back and check and see that the cost, the out-of-pocket cost, has been updated to reflect that. Okay, I think that's everything to show there, so I'll hand back to Rob to talk about some of the strengths and limitations of our work.
Awesome, thank you. So yeah, so that's kind of an overview of the platform and the tool, and that's really what we've kind of specialized in, is how can we make some of these algorithms that might otherwise be written up in a paper, how can we make them more kind of transparent and usable for decision makers in commissioning decisions. So in terms of the strengths, I think that's kind of one of the big strengths is we're data driven. We've got some great data in the UK on these LSOAs. Accessing information about the site locations is fairly easy as well. And then we have some good mapping software too that's open source and we're able to do kind of live. There's a lot of structural flexibility. So I think the biggest benefit of trying to do this in kind of ourselves in R and C++ versus other off-the-shelf software GIS type packages is that we can then adapt this now. So we've kind of got a structure, but we can continue to build in more functionality and features as needed on different projects. And we can also open source. So we're using the open source mapping software. But the R engine, so the greedy search engine that Oliver went through, will be made open source as an R package. And obviously all of the work that we did before that was funded by Wellcome is already open source. So kind of others can build on this and take it and run with it. And yeah, we hope that it provides actionable insights that commissioners can log on and use it and understand how to improve access in their area. In terms of the limitations, there's still things that we would like to do to develop it. Currently, the travel model, so the distances traveled, is based upon driving distance only. So it would be really nice to have public transport in there. It needs quite a bit more work to be able to do that, because then we need to understand what the propensity to travel upon different modes is depending on your location. But it's something that others have done and something we can build in. The behavioral validation component and the distance traveled and different types of treatment by distance is really the thing that we need to understand more and elicit those either from experts, from clinicians, or from real-world evidence studies, and that's something that we'd love to get feedback from the research community on. And finally, it's at the moment a purely quantitative tool, so we don't have any qualitative insights kind of augmenting and telling the story, and we hope that we'd be looking to collaborate with other people to try and kind of provide those insights and build those into the tool as much as we can. So yeah, so I think that's kind of roughly where we're at the moment. And yeah, I'd love any questions and feedback. We'd be really keen.
Great, thanks, Rob. One question I had was thinking about urban versus rural differences and propensities to travel, and how, going a mile or 2 miles in London might take a lot longer than, someplace else. Is that captured in the open source, the OSMR or whatever that is?
So
Or how do you
current,
think about that difference?
so the way it currently works is using the speeds on different roads at kind of a non, so it doesn't incorporate traffic, but it
Okay.
incorporates the speed of the roads. So in London, where lots of the roads might be slower, um, or in very urban areas where you have like 30 miles an hour speed limit and things like
Yep.
that, it incorporates that, but it does not incorporate like traffic. So if your
Gotcha.
appointment's at 9 a.m., then yeah, like maybe you choose to take the train instead. It doesn't incorporate that.
Okay.
But it does incorporate the fact that like in rural areas, you'll be traveling on the motorway, say at 70 miles an hour versus in the cities at 30.
Okay. Thanks.
So we had a question from Danway. Can I select both optimal travel time and treatment administrations?
Do you mean combining the outcomes, so kind of weighting? I'm assuming you mean sort of weighting both of them in some way.
Yeah, when you presenting the website, it's really fascinating because we can interact and put the select outcomes that we want. Uh, so I'm curious, like if we can select like both optimal outcomes for travel time or like the treatment administration, because this is usually how I consider like I want to balance between the travel time, also the treatment.
Yeah, that's a great question. At the moment, we don't have that functionality, but would not be too difficult to implement something where you would just have a simple weighting of both outcomes and then sort of
Mhm.
kind of combine them. But that's not something we're doing at the moment. But yeah, that's a good point.
So there's a few different things we could do. So we could show both. So we could run both and then show them overlaid on the map where the optimal sites were. Or I think what you're probably referring to is having some weight where you would say I place 30% of my weight on travel time and 70% on administrations, and then build that as kind of a new custom objective function, and then run
Mhm.
that through. That would be quite quick to do. Like we could adapt
Yeah,
the tool in like a few hours to do that,
Uh-huh.
and so that's a good suggestion.
yeah.
Uh, and Albert had a question. Is this meant just fixed clinic sites, or can it also consider mobile health units?
At the moment, it's just meant for fixed clinic sites. Yeah. It's not built in a way where where the kind of potential sites could be placed anywhere. Um, yeah,
And the,
which
the reason for that is just to limit the compute, because if we have an unlimited number of locations, then our compute gets really high. Like the theory, like the concept still applies exactly the same. It's just we are doing this search through, say, 1,000 or 200 candidate sites, hundreds or thousands of candidate sites, and that works in a short time frame. If we have like any location in England, this would be, would need to do say 33,000 or use the LSOA locations. The compute time would be really long. We would be able to do it. It would just probably take maybe like an
be a
hour
lot. Yeah,
rather than a couple of hours rather than seconds.
we might have to
Yeah.
change the approach if we were just trying to find the best point as opposed to considering from a discrete set of pre-existing potential sites. Hope that answers the
Can you hear
question.
me?
Yes.
Yeah.
Thank you for that answer. Yeah, the reason I'm asking is that we have some slightly crazy ideas about so basically public health outreach for specific problems like high blood pressure, where the idea is to send mobile vans with practitioners to different sites. Seems like a pretty crazy idea because you'd have to go to places where people are, and then people would have to want to go to the mobile van. But anyway, that's kind of I see your tool as potentially a way to answer that question, which public health people are always trying to answer. Where do we send our limited people resources? What geography is optimal?
I think that makes sense. I think what would, yeah, I think that's a really good use case. I think I suppose what you'd probably want to do anyway is come up with a fixed list of possibilities to start with. Like it might be like shopping centers or something, or family health clinics, or some like a really large number of a place where there's a large number of options. It might be like thousands of options, but at like fixed locations. Rather than on the side of a road somewhere, like or in a quarry or something. So like it's just kind of narrowing it down to like a manageable, sensible set of locations. Something like shopping centers or the LSOAs themselves would limit it enough so that we could then run the algorithm through.
Thank you.
Thank you.
Cool. I'm wondering, is a question to the group is has anybody got any experience on working with kind of distance to treatment and the effect that has on treatment decisions? I didn't know whether there's anything anecdotal or in the published literature. We've done a mini review and found very little. We've really struggled in this on this topic.
There is some research that looks at distance to pharmacies and how that may influence people's adherence to medications. I can send you some of those papers, but that comes to mind. And also, people would do similar sort of distance to hospitals when thinking about the competitiveness of a region when they're trying to figure out kind of antitrust issues. I could also send you those papers as well, Rob. But as far as I don't know other papers outside of that, those two areas.
Rob, so actually the classic instrumental variable analyses, like by McClellan for distance to a cardiac catheterization site, those are cases where the distance is used as a reason someone does as a to account for selection effects. So that's kind of classically how it's been used, going back decades, 2 or 3 decades. So that's I think of when people are always looking for instrumental variables, they frequently think about distance as a reason for higher or lower use of a treatment or technology.
That's what I had not thought about that. That's really, that's super useful. Yeah, okay. Yeah, we can get in contact with also because actually they're using it as the instrumental variable, but actually it's the variable that we're interested in. So yeah, that's awesome. Okay. Yeah, very nice.
What was the work that you mentioned?
It's very old. I mean, this is like classic health economics. Aaron, you can confirm, right? There's a JAMA
absolutely.
paper. Mark McClellan he became famous for that application, but it's like in the 1990s, I think.
Yeah,
I'm that old.
Awesome. Okay, no, that's brilliant. That's really nice because the other thing we're looking at that we've not built in yet, but we can build in is we in the UK have the NHS has made prescribing data open source, open access, so we can actually see the prescribing characteristics of each region, each trust, so each hospital. They're like only a couple of months delayed, so we can actually for some treatments for which that treatment is only serves 1 or 2 indications, we can kind of make some guesses, like pretty decent guesses in there. But what would be really nice is to really understand that causal relationship rather than just the descriptive relationship between distance and prescription. No, thanks so much. Cool. I don't know if there's any other questions.
I'll just add one more comment. I don't know what it's like in the UK, but our prescriptions are frequently now mailed to people, so they don't pick them up as much. So that's just something that I don't know what it's like. I'm not sure what it's like that's especially for chronic disease medications where there's some regularity in the need for medication.
Yeah, what we're thinking of here is like if it's like an IV or subcutaneous injection, that is healthcare professional administered. And then you can switch, like potentially look at the benefits of switching between that and oral daily and trying to understand these relationships with distance as well. So it's kind of anything that's healthcare professional administered. What would be the effect, say, of moving from that being administered in a hospital to that being administered in a local pharmacy or a local kind of health clinic? That might bring the distance down from 100 kilometers to 3 kilometers, 4 kilometers. Yeah, that's the kind of thing that we're kind of a best use case probably for the tool. Yeah. Awesome. Well, thank you so much. Yeah, really nice to be able to present this stuff and a nice follow on from the parkrun work.
Yeah, thanks so much for being willing to come back. And it's so cool to see how you've been able to expand this work into new areas to ask new questions, but still kind of utilizing the same framework to get there. So again, thanks so much for being willing to come back.
Cheers.
Thanks for having us.
We're off for pizza. So yeah,
Okay.
enjoy your work day.